Thank you to session chairs and SAGES for giving me the invitation to share my experience with virtual incision. What is the current status of robotics in surgery? Less than 10% of operating rooms offer access to robotic-assisted surgery because it's expensive, and it's also due to dedicated OR space, extensive staff training which is needed, complex scheduling, and everybody wants to be on the robot. And typically a hospital will have 1 or 2 robots, and long turnover times. And making the robot miniature can overcome these challenges. So the MIRA surgical system, which MIRA stands for Miniature Robotic System. It's the console, which is ergonomic with the upright seating, and which is a lot more ergonomic than we have current robotics. The mini robot with a camera and the companion cart. If you look at it, the internal triangulation and dexterity is available with MIRA with a small footprint, as opposed to the traditional robotics, which is the triangulation is outside. And so less collision of the instruments, of the arms outside, which is better ergonomically as for the surgeon as well. The shoulders and the elbows, they allow infinite instrument roll, and then you have 70 plus camera sweep, and a 90 degree arm sweep, actually. This is what the docking looks like. It's basically the robot which doesn't need any draping, and it is handheld, and then it can have a system which can dock it to the side of the bed. And you can see the arm. It's basically a single port robot, and then once the surgeon puts a robot into the abdominal cavity, and then can sit down on the console, and the arms are moving. So it will be ideal for anybody who's interested in doing a more single port surgery as well. This is the setup. The video has been shared by Dr. Jobs, who has had extensive experience with MIRA initial development and studying the patient outcomes in this. It shows how the time to utilize this is there's a real-time number on the clock on the screen, which shows how little time it takes to set it up and then and to start going. And I'm going to skip this portion of it because I'm going to show a later video showing how it looks like inside the abdominal cavity. Another thing is because it's docked on the side of the bed. You don't need to take the instruments out, move things around to be able to do the patient movement on the table. And the anastomosis, most of the time, based on the surgeon's technical abilities, it either can be done intracorporeal or extracorporeal. And now, MIRA does not have, as far as I remember now, right now, that it does not have a stapler, and the energy device is usually cautery with the scissors, but the vessel sealing device is in progress. So this is and then shout out to Dr. Jobs and Dr. Olkinov. That MIRA just got FDA approved in February. It was announced at SAGES Disruptive Technology meeting in Houston. This is a paper which is being published in DCNR, which looked at 30 patients with a 30-day follow-up, and which performed 100% of the mobilization dissection in all these cases. There were no unexpected adverse events, and it's safe and effective. So I'm just going to go more over the data a little bit more in detail. So it was a prospective multi-center, multi-operator, non-randomized, consecutively enrolled clinical trial. The study centers were Lincoln, Nebraska, Wynwood, Pennsylvania, and Charleston, South Carolina. The study characteristics were, you can see there were 30 patients. Initially, they had looked at 136 patients, but 30 were finally included in the study, which based on the inclusion-exclusion criteria. The most common age is between 55 and 75, and predominant and most 43% of the patients were overweight, and the ASA classification is 2 and 3. This is what the right colectomy the MIRA technique looks like. The gel port which is used to introduce MIRA is placed periumbilical, either in the midline configuration or off to the side. And then you need to have a 12 millimeter assist port because there's no stapler. And with the two arms, you do need another assist port for help with mobilization and retraction. As a colorectal surgeon, we always advocate medial to lateral approach. So the right colectomy technique is medial to lateral with intracorporeal dissection and mobilization and skeletonization. And then anastomosis, like as I mentioned earlier, either can be extracorporeal or based on your surgical skill can be intracorporeal as well. The primary endpoint was the efficacy of this, how safe it is, and how is it to be, can MIRA be used to have successful completion of right and left colectomy without conversion to open surgery. And the second primary endpoint was safety, and how does it compare to other techniques available and overall operative and postoperative adverse events compared to published literature. These are the secondary and tertiary endpoints. We all know what we look at when we are looking at our data is length of stay, which is very important. But I think it's not so much as robotics versus it compares to open and robotics, but not other, across the board of robotic techniques. Looking at intraoperative adverse event, which is more important for this robot, and looking at transfusion, conversion rate, and operative time. So as I mentioned earlier, the 165 patients were initially screened, and then eventually 30 patients were enrolled in the study. And 13 patients had completed the follow-up. It's a repeat of the previous slide. So there were equal number of right and left colectomies. The most common indication was actually colon cancer, which was at the final pathological diagnosis, it ended up being 17 patients. So close to for 50% of the patients. 53% patient had prior abdominal surgery. The TNM stage is at the bottom. So length of stay, the median length of stay was 2 days, and the range was 2 to 26 days, and the 26 days, and the 26 days was a patient who had actually had a leak. Estimated blood loss is comparable to all other techniques, and number of laparoscopic ports. Sometimes another port was needed at 36% of the times. Operative time actually is interesting. 163 time total. It says 163 minutes total operative time, and then 77 minutes console time. So incision length, 5.6 centimeters. That's the gel port which is used to introduce MIRA in the abdomen. And so primary endpoint was met in 100% of the cases. All 30 cases were completed without conversion. And then secondary endpoints, so looking at transfusion rates were comparable to published data, 3.8 to 5.8% compared to 3.3 in the study. And then median operative rate was, the operative time was comparable as well. And one patient in the study required a second operation, as I mentioned earlier, due to an anastomotic leak, which was a 73-year-old patient who had a punctate leak, which was identified at post-op. He was taken in the OR post-op day 13. Initially, he was managed conservatively, but and got septic and was taken back to the OR. But since the anastomosis was performed extracorporeally, so it is not the function of the robot as much as the function of the patient as well as the technique itself. Looking at the adverse events, this is a really busy slide, but all subjects reported some type of minor self-limited postoperative pain, which expect with a 5.6 centimeter incision, and no device-related adverse events were noted, and overall complication rate was 33%. Again, it compares to all the data in the literature. There were no deaths. So MIRA has comparable safety profile. It has 0 intraoperative adverse events, and 30-day operative complication rate was 33%. All right, how do I go back? The study concluded that MIRA was safe, and then after the study, it received FDA approval. So now I've used MIRA in the lab, and my experience in the lab was the beauty of this robot is it does not have a heavy a large footprint, and the draping is not needed. So sustainability, which Sages is all about sustainability and decreasing the cost. And it has a little bit of learning curve because it's a single port robot with the flexible arms if you're a robotic surgeon. But laparoscopically, I think it will enhance a MIS surgeon's personal technical abilities. So, and then recently, MIRA made news by CNN. Space MIRA. It was made possible because of the miniaturization of this robot, and it was successful remote surgery simulation done at the International Space Station. So, in conclusion, MIRA complements and augments robotic surgery. Certainly, is not going to replace the already big robotic system we have available, but it will augment and complement whatever MIS surgery we have already available. It is approved for colectomies in US by FDA. And then the real advantage of MIRA is going to be robotic surgery is going to be more accessible because not everybody can, not every hospital or not every country can afford to have, and not every economy can afford to have the bigger health, robotic systems. Thank you.